We're often told how AI is the ultimate assistant, a tireless intern that will finally clear our admin piles and let us get back to our patients. But today I want to look at a much bigger picture and perhaps a more unsettling picture. We're discussing a provocative new analysis by Trammell and Dwarkesh Patel titled Capital in the 22nd Century, published recently. It's a very deep dive into the ideas of the famed economist Thomas Piketty, and it has some profound implications for the future of our own profession. To understand where we're going, we have to understand Piketty's core big idea. Back in 2013, he argued that wealth naturally concentrates in the hands of the few because the return on investment, what he calls capital, tends to grow faster than the rest of the economy. In his view, unless there's a massive shock like a war or a heavy tax, the rich simply get richer while the workers stay stagnant. Now, the authors of the text point out that Piketty was actually wrong about the past. Why? Because of us, because of human labour. Historically, when a hospital bought a new MRI machine, that's the capital, it didn't make the radiologist obsolete, it made them more productive. The machine and the human were complements. As the tech improved, the value of the expert using it went up. But Trammell and Patel's central warning is this: in the age of AGI, that relationship is about to flip. They argue that we're moving from a world where AI is a tool we use to a world where AI is potentially a substitute for what we do. If they're right, then we're facing a massive hurdle. In economics, this is a shift from the Baumol effect, where our wages rise because we become more efficient, to the Jevons paradox, where the machine is so capable that the human worker is no longer the bottleneck. In a healthcare context, if an AI can diagnose, prescribe and monitor patients as well as a human, the economic value shifts entirely from the clinician to the person who owns the algorithm. The authors summarise a sobering future where wealth becomes locked in a cycle of extreme concentration, primarily because the most foundational AI breakthroughs are occurring in private markets, elite startups and venture-backed labs. They're fundamentally inaccessible to the average person or public institution. This privatisation of returns means that astronomical profits generated by automation can be captured by a tiny sliver of elite investors, while the broader workforce sees the economic value of its labour diluted. Even more concerning is the predicted end of international catch-up growth. So for decades, developing nations have used their human labour force as a ladder to climb the global economic stage. If AI renders significant portions of that labour obsolete, then the primary engine for global equity is dismantled, leaving those nations without a viable path to fund their own infrastructure or compete in a world where capital, not people, drives all productivity. So why should we as busy clinicians or health managers care about capital shares and substitution effects? I think the shift potentially changes the why of your career if it does occur. If the value of clinical labour drops towards zero while the value of AI capital skyrockets, then the noble profession of medicine faces a massive identity and financial crisis. We could see a future where healthcare is delivered by trillion-dollar private entities, while clinicians, once the leaders of the system, become low-cost supervisors of software. This isn't just a professional grievance, it's a profound risk to global health. When profit-motivated capital replaces clinical labour as the primary driver of care, we risk a kind of algorithmic extraction where systems are optimised for billing and shareholder returns rather than for patient outcomes. Without the human clinician's autonomy, we lose the essential safety valve of professional ethics that protect patients from biased, black-box decisions. If in the future we see a world of fully automated private equity-driven care, this risks creating a two-tier system where the wealthy can access human oversight, while the rest are managed by de-skilled supervisors unable to intervene when the algorithm fails. This erosion of trust and loss of human-centred accountability is a hurdle that I think we must ensure we solve for if AI is to truly heal the world rather than just bankrupt it. So how do we bridge this? How do we make this work for us and our patients? The how-to isn't just about better tax policy, it's about clinical equity. We need to ensure that the capital of healthcare, the data, the models and the infrastructure, is not entirely privatised. We don't currently have a model for community-owned AI, and I think we should be advocating for healthcare systems like the NHS or global cooperatives to own some stake in the equity of the AI models they help train. If our clinical expertise and our patient data are the raw materials of this AGI system, then the returns on the capital should flow back into public health, not just to a handful of private investors. We need to move from being users of AI to being stakeholders in the capital itself. Right now, the claims of this article's authors are theoretical, based on economic modelling rather than peer-reviewed clinical trials. But I think we do need to ask, does this technology empower the clinical workforce, or does it simply strip and mine their expertise into a private asset? I've seen this tension firsthand. Almost every decision regarding AI use in healthcare is currently focusing on business models and return on investment to justify the spend. We want to improve metrics, things like reducing waiting lists, increasing throughput, and making things cheaper in order to justify the expense. But I think we need to be incredibly careful about what we optimize for. In a world of pure efficiency, the ideal patient for a business case is actually a dead patient. They're not on a waiting list, they require no further resources, and they cost the system nothing. If we treat healthcare purely as a logistics problem to be solved by private capital, we lose the drive for quality of care and population health. We risk replacing the goal of wellness with the goal of throughput. We must be pragmatic optimists. AI can definitely help solve some massive productivity crises in healthcare, but we can't ignore this kind of Piketty trap. We must ensure that as labour becomes less of a bottleneck, the clinical community doesn't lose its voice or its value. This is why our bridge forward must involve public equity in AI models and a radical reimagining of clinical metrics that prioritise human life over some sort of spreadsheet efficiency. We aren't just protecting our jobs, we're protecting the human-centric, fundamental soul of medicine. That's all for today. If you found this useful, don't forget to hit like and subscribe so that you don't miss future episodes.